Okay, so we want to turn off.
Hi, this is Joseph Barone. I'm the clinical pharmacy specialist for the West Cancer Center, and today I wanted to provide a presentation to you regarding chemotherapy-induced nausea and vomiting, which is also abbreviated CINV, which I'll use throughout the presentation today. This slide discusses the pathophysiology of chemotherapy-induced nausea and vomiting. As you can see here in the background of this picture is your brain, which plays a major role in the nausea and vomiting process. Pretty much what happens is when a patient's administered chemotherapy, it will cause a direct insult to the lining in the gastrointestinal tract. And from the gastrointestinal tract, several substances are released. Dopamine is released, serotonin is released, histamines are released, and these will travel from the intestine into a center of the brain, in the rear of the brain called the chemotrigger zone. From there, messages are relayed to the vomiting center, which is in the midbrain or the medulla, and that will cause the patient to vomit. Now, the different areas of the brain that are important here are in boxes in blue lettering. The sites of specific drug actions, as you can see here, 5-HT3 antagonists, histamine antagonists, muscarinic antagonists, dopamine antagonists, are in orange, and I'll discuss these drugs individually in a little while. Also in the higher cortical centers of the brain, this is where pain, smell, and sight come in and are responsible for something called anticipatory nausea, which we'll discuss later on. There are 4 different types of chemotherapy-induced nausea and vomiting. The first of those is acute, and acute chemotherapy-induced nausea and vomiting occurs within 24 hours of chemotherapy administration. The next one is delayed, which pretty much is anything that happens once you get outside of the 24 hours following chemotherapy administration up to as late as 5 days after chemotherapy administration. Anticipatory nausea and vomiting is a conditioned response. This is something that happens when you can see a patient merely just show up here at the West Cancer Center, walk through the door, and immediately feel like they're nauseous. If that happens, for example, the first time they ever get chemo, they may recall that feeling and become nauseated every time literally every time they come to the clinic for chemotherapy infusions. The last type is breakthrough nausea and vomiting, which is something that occurs despite us administering preventative antiemetics or anti-nausea, anti-vomiting drugs, and this requires administration of separate rescue medications. The next thing I wanted to talk about were risk factors for the development of chemotherapy-induced nausea and vomiting. Now, there are 2 types of risk factors. You have negative risk factors, which if you have these, you may be more likely to develop nausea and vomiting, and you have positive risk factors, or really more so protective factors, where if you have these, you may be less likely to develop the nausea and vomiting with chemotherapy. Aside from the chemotherapy drugs themselves, which I'll talk about on other slides, your negative risk factors are going to be having nausea and vomiting from a prior chemotherapy cycle. This is a big thing. If you have a patient that develops nausea and vomiting on their first ever cycle of chemotherapy, they'll usually go on to have it on subsequent cycles. It can sort of become a runaway train. Other negative risk factors, if you aren't a drinker, if you aren't a smoker, if you have motion sickness is a big thing, if you're a female, and if you're a younger patient, younger than 50 to 55 years old, any of those are risk factors for developing chemotherapy-induced nausea and vomiting. The protective factors are obviously not having chemotherapy-induced nausea and vomiting with a prior cycle, patients who are alcoholics have actually been seen in trials to not develop as much nausea and vomiting from chemo as patients who don't drink. If you've been pregnant before, that is a protective risk factor, and males are less common than females to develop CINV. These are the medications that are used to prevent chemotherapy-induced nausea and vomiting, and again, the point of this slide is the prevention of it. These drugs that you see here cannot be used to actually treat active nausea and vomiting. The first class that you'll see are the 5-HT3 or serotonin antagonists, and these are drugs that will block the serotonin receptors in your in the chemo trigger zone and in the vomiting center from the serotonin molecule actually attaching to those receptors and causing the patient to vomit. Here I've listed all of the available presentations of that drug class. You have ondansetron or Zofran, and that's available as IV or PO. The maximum dose is 16 milligrams as a single dose. The next one is palonosetron or Aloxi, which is only available as an IV formulation. Aloxi is the longest acting drug in this class with approximately a 40-hour half-life. So what this means is that if you administer this to a patient on day one of their chemotherapy regimen, that it's more likely than not going to work to cover them for at least 3 or 4 or 5 days after the administration of the Aloxi. Again, that's only available IV. Other agents in this class are granisetron or Kytril or dilasitron and Anzimet. Those are less commonly used here at the West Clinic. As a sort of as a class comparison, the 5-HT3 antagonists are likely to cause headaches or constipation. The next set of drugs are the neurokinin-1 antagonists or NK1 antagonists, and this is Emend, which is available PO or IV, Varubi or Relapitant, which is PO, or Akenzio, which is a newer combination pill of nitupetant and palonosetron. Now, also along with serotonin and dopamine and different neurotransmitters, when patients receive chemotherapy, the gut will also release something called substance P, which acts on the neurokinin-1 receptors in the vomiting center. So that sort of explains where this class of drug acts. Similar to the 5-HT3 antagonists, your similar headache and constipation side effects. And another important drug for the prevention of chemo-induced nausea and vomiting are corticosteroids. The most common one we use is dexamethasone, which is the brand name Decadron. This is available IV or PO. Common side effects include hyperglycemia, hypertension, upset stomach. Patients can also develop insomnia and psychosis even from one dose of a corticosteroid. And it's important to note that the neurokinin-1 antagonists can increase the blood levels of the corticosteroid drug class, so you may see some increased corticosteroid side effects. This is a list of medications that are used to treat breakthrough chemotherapy-induced nausea and vomiting. And again, breakthrough would be if you've given a patient a 5-HT3 antagonist and their steroid and their neurokinin-1 antagonist, and despite all that preventative measures, they still develop nausea and vomiting. The key to treating breakthrough nausea is to administer a different drug from a different drug class that wasn't used in the preventative phase to sort of hit them with a new mechanism of action. And there's various drug classes listed here. Benzodiazepines, the common example is lorazepam or Ativan, that's available IV, PO, or even IM. This is also used for anticipatory chemotherapy-induced nausea and vomiting prevention. If you remember earlier, anticipatory nausea and vomiting is when a patient knows they're coming for chemotherapy and just the feeling of being in the clinic or seeing IV bags or getting stuck with a needle just makes them nauseous. Other agents which can be used are atypical antipsychotics such as olanzapine or Zyprexa. This is a PO tablet. Other agents include dopamine antagonists. Compazine and Phenergan are commonly prescribed, and they're available in a wide range of administration routes. Phenergan is kind of interesting in that it has a rectal suppository formulation, so if you have a patient that is actively vomiting and they can't take anything by mouth and they can't come into the clinic to get an IV, that can be administered rectally. You have cannabinoids such as Marinol. Scopolamine patches can be used, especially if you have a patient who also has a history of motion sickness. And some older, more toxic drugs such as Haldol and Reglan have been used in the past. They've sort of fallen out of favor due to the risk of tardive dyskinesia. And I've listed the side effects of these assorted drug classes. The most important thing is all of these medications you see here can cause somnolence or CNS depression or make the patient feel sleepy. The National Comprehensive Cancer Network, or NCCN, categorizes chemotherapy regimens based off of their potential to cause nausea and vomiting. And what I mean by potential to cause nausea and vomiting is if you don't give a patient an antiemetic, a certain percentage of them will have nausea and vomiting. Highly emetogenic chemotherapy regimens are those where over 90% of the patients will have emesis if you don't give them any preventative medication. Moderately emetogenic regimens are those where 30 to 90% of the patients will have emesis without any preventative medication. Low emetogenic medications are those where 10 to 30% of the patients will have emesis despite or without any preventative medication. And then minimally emetogenic patients, less than 10% of them will have emesis. This is a table from the NCCN, which is fairly comprehensive. And as you can see here, these are your IV chemotherapy drugs that are highly or moderately emetogenic in nature. The common ones from the highly emetogenic category include cyclophosphamide or Cytoxan if it's above 1,500 milligram per meter squared, ifosfamide, high-dose doxorubicin, any dose of cisplatin, and it specifically lists a very common chemotherapy regimen, AC, which is used for breast cancer. That is the combination of cyclophosphamide and doxorubicin. So those would be your highly emetogenic group of drugs. Your moderately emetogenic group of drugs is a little bit longer of a list, and some common drugs include bendamustine or Bendeca, carboplatin, other anthracycline chemotherapies such as epirubicin, idarubicin, irinotecan, oxaliplatin. This is a list of your low and minimally emetogenic chemotherapy drugs. Again, these are longer lists than the prior classes. I'm not going to sit here and read them all to you, but you can just go through those at your leisure. Some common ones for your low group are docetaxel, fluorouracil, and your minimally emetogenic group of drugs are mainly going to be your monoclonal antibodies, such as Rituxan is a common example. This is a table from the NCCN guidelines of how you prevent both acute and delayed chemotherapy-induced nausea and vomiting from occurring in the first place. This is a table for your highly emetogenic IV chemotherapy drugs. So in these patients on their first day of therapy, you would want to give them a neurokinin-1 antagonist. Again, an example of that is Emend, and you can see that here. You have both PO amend and IV amend. You'd want to give them also a 5-HT3 antagonist, which if you're using your highly emetogenic group of drugs, you'd want to typically use aloxi or palonosetron because that has a longer half-life than Zofran. And then additionally, you'd also want to give your patient a corticosteroid such as dexamethasone. Now that's day one. We can't just give these patients medications solely on day one of their chemotherapy regimen. You have to give them on subsequent days. So on days 2, 3, and 4, actually let's start with days 2 and 3, they would get IV Decadron or PO Decadron at home on those days. That actually helps prevent the delayed nausea and vomiting, which again is having nausea and vomiting from chemotherapy more than 24 hours after its administration. Other regimens you can see down here are your Akenzio or your nitupatance palonosetron combination pill with dexamethasone. Now that pill encompasses a neurokinin-1 antagonist and a serotonin antagonist in a pill. And as you can see in the right-sided column for days 2, 3, and 4, you would administer your corticosteroid orally at home. I cannot stress the importance of making sure that the patient has that steroid on days 2 and 3. That will greatly help prevent delayed nausea and vomiting. This is a table of how you would prevent nausea and vomiting for a moderately emetogenic IV chemotherapy regimen. You would, as in the highly emetogenic regimen, you would use a serotonin antagonist and a corticosteroid. In this moderately emetogenic category, you have the option of either using or not using a neurokinin-1 antagonist such as amend, and this largely depends on your patient's risk factors. If this is a patient with a recurrent cancer that's gotten chemotherapy before and they may have had a negative experience with nausea and vomiting in the past, you may want to consider using amend for their moderately emetogenic chemotherapy regimen. Also, if you have a young patient or a female patient, a patient who's never been pregnant, one of those negative risk factors, you should err on the side of caution and use amend because you really upfront want to control this nausea and vomiting before it becomes a runaway freight train. And also on day 2 and 3, you would want to give your patient their corticosteroid at home to help prevent the delayed emesis again. For your low and minimal emetogenic risk categories, first for low, you don't have to give them a combination of medications. You can either give them just the steroid or just the 5-HT3 antagonist, and that will usually suffice for those patients. And your minimally emetogenic category, which is most of your monoclonal antibody drugs such as Rituxan, for example, if they're given single agent by themselves, you don't have to give them antiemetic prophylaxis at all. I just wanted to go through some general rules of thumb, which are sort of clinical pearls or teaching points. The first one is cisplatin. Cisplatin is an agent that's used in clinical trials as a highly emetogenic based regimen when investigators are actually studying whether or not a new antiemetic drug works. And cisplatin is one of, if not the most emetogenic drug out there. So if you have a patient that's getting a cisplatin-containing regimen, whether it's weekly cisplatin by itself, cisplatin plus etoposide, whatever it may be, those patients have to receive a 5-HT3 antagonist, a corticosteroid, and a neurokinin-1 antagonist on day 1 without fail. The next thing I wanted to talk about is, while I showed you these charts of how the NCCN individually categorizes each drug, high, moderate, low, minimal, most of our chemotherapy regimens are combinations of 2, 3, possibly 4 agents. So I just want to give an example of what one should do if you're confronted with a multi-agent chemotherapy regimen. And again, you need to err on the side of caution. The first regimen I wanted to discuss was carboplatin plus paclitaxel or Taxol. This is a very commonly used regimen here at the West Cancer Center. If you look at each drug individually, carboplatin is moderately emetogenic and paclitaxel is low emetogenic. When you're administering a combination regimen like that of a moderate and a low, you would always want to treat the regimen collectively as whatever the higher emetogenic risk is. So moderate is higher than low, so you're going to treat that as moderate. So you would give a patient a serotonin antagonist plus a corticosteroid and maybe a neurokinin-1 antagonist depending on the risk factors. The next one I wanted to discuss was the regimen of fluorouracil or 5-FU plus oxaliplatin plus irinotecan. It may be commonly referred to as FOLFIRINOX. Fluorouracil individually is low, oxaliplatin individually is moderate, and irinotecan individually is moderate. The way I usually discuss this is 2 moderates equals a high. So this would be treated as a highly emetogenic chemodtherapy regimen. So you'd do automatically a serotonin antagonist, a corticosteroid, and a neurokinin-1 antagonist. This is just some more general rules of thumb. It's very important that once you've infused your IV antiemetic premedications, you don't just immediately go and start your chemotherapy infusions. Once your antiemetic premedications have been infused, you would want to wait at least 30 minutes prior to starting the chemotherapy IV infusions. This will allow the drugs time to work in their receptor targets. And again, as I mentioned before, we don't just give antiemetics only on day 1. You need to make sure your patients are taken care of when they're at home on days 2, 3, and 4. Palomalcitron or Aloxi and the neurokinin-1 antagonists are only to be used in patients that are receiving highly or moderately emetogenic chemotherapy regimens. Again, if you go back to your low category, you can just give these patients merely a corticosteroid or just Zofran. And again, as I mentioned earlier, if a patient develops breakthrough chemotherapy-induced nausea and vomiting, you would want to add a medication from a different drug class that wasn't used during the prophylactic antiemetic administration. For example, a benzodiazepine like Ativan, a dopamine antagonist such as Phenergan or Compazine. These aren't really medication-based rules of thumb, but in general, you want to tell the patient to avoid eating foods that may trigger nausea and vomiting, such as spicy or greasy or fried foods. In general, you'd want to recommend that the patient have small snacks in between breakfast, lunch, and dinner, the 3 meals of the day. This will help kind of make sure that there's always food on the patient's stomach, and sometimes that helps with nausea and vomiting, sometimes it doesn't. And then another key thing is you don't want to forget about the patient's hydration status. If you're vomiting multiple times a day, you're losing fluid. And these are sick patients. They may forget or may be too weak to drink. You want to always encourage adequate PO intake in your patients. And if it's just, again, the runaway freight train, out of control, can't be managed at home, do not hesitate to bring the patient into the clinic for IV fluid administration. I just wanted to run through a patient case study, and we'll have some follow-up questions with it. So SA is a 35-year-old female patient with a newly diagnosed stage 3 diffuse large B-cell lymphoma. She has a past medical history significant for hypertension, severe motion sickness, and diabetes. The physician for SA ordered the chemotherapy regimen called R-CHOP, which is to be administered every 3 weeks for 6 cycles. And I've listed out the drugs here for the R-CHOP, which are rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone, and there's your schedule of administration. And then take-home medications prescribed include prochlorperazine or compazine as needed for breakthrough nausea, Docustate as needed for constipation, and Magic Mouthwash as needed for mouth care. So with that being said, how would you classify the emetogenic potential of the RCHOP regimen? Question number 2, what risk factors does SA have for the development of chemotherapy-induced nausea and vomiting? Which is an appropriate antiemetic pre-medication regimen for SA? On day 3 of SA's RCHOP cycle, she is at home and not feeling well. SA contacts her physician's nurse and says, I just threw up once. What should I do? What type of chemotherapy-induced nausea vomiting is SA experiencing? You are the physician nurse who just received this phone call from SA. What would you recommend? And with that, I'd like to conclude this presentation on chemotherapy-induced nausea and vomiting.